I'm Dr. Ronald Berkman. This is part 2 of a lecture series dealing with nausea and vomiting in pregnancy, treatment fit for a queen. First, I'd like to indicate that I have nothing to disclose. At the end of this particular presentation, the participant will be able to list possible treatment approaches, utilize an algorithm for the management of such patients. Part 1, discuss epidemiologic features of the disorder as well as listed possible etiologies. Certainly the initial approach should always be the prevention of the problem, and there is at least one approach, to reduce perhaps the risk of nausea and vomiting in pregnancy. One should attempt to start prenatal vitamins ahead of pregnancy, especially before fertilization. This not only provides folic acid, which we again utilize to reduce the risk of neural tube defects, but also leads to increased levels or accumulation of vitamin B6, pyridoxine, which may reduce symptoms in some women. Once pregnant with symptoms, one should give only folic acid, since components of prenatal vitamins, especially iron, may exacerbate symptomatology. Once pregnant, obviously one of the first non-pharmacologic approaches is to deal with diet in some way. And certainly it's been suggested in several publications that small, frequent meals should be offered. These meals should be protein predominant and oftentimes salty or bland in taste. One should avoid spicy, fatty, or odorous foods such as, for example, fried fish or Mexican foods and the like. Fluid should be cold, clear, carbonated, or sour in small amounts. Now, despite these recommendations, it's important to understand that there is no good data that indicates this approach or modifications of this approach is in fact more useful than other approaches. Other non-pharmacologic means would be to avoid triggers, whether these be visual, auditory. Also, acupuncture and acupressure has been utilized, and we'll discuss this in a little more depth in a moment. Hypnosis has been utilized, but there's not a lot of evidence on its use in terms of reducing or preventing this particular problem. Finally, ginger is another of the so-called non-pharmacologic approaches, which we will discuss also in a moment. So the P6 acupressure point is where acupuncture is applied. And this point is basically 3 finger breadths above the proximal wrist fold, between the palmaris longus and flexor carpi radialis tendons, and this is where the ballpoint pen point is pointing. Here one can apply pressure with one's own fingers, or can utilize a wristband that applies such pressure. Obviously the question is, does this in fact work, since it is a relatively simple approach to managing a problem that many women have during pregnancy. And there have been 4 randomized controlled trials with a total of 408 subjects which have compared this P6 acupressure to placebo. But these 4 trials showed no statistically significant effect of the acupressure on nausea, vomiting, and pregnancy. One randomized trial of 66 subjects which compared P6 acupressure to pyridoxine also showed no difference between the 2 groups, but again, it did not seem to be too likely that there was a substantial benefit when only 1 randomized trials out of several showed a benefit. And this has led the Cochrane reviewers to conclude that the use of acupressure at this particular area is no more effective than sham therapy. But there is a large placebo effect often seen in sham therapy, which may explain why some individuals feel that it is beneficial. The effect of ginger on nausea and vomiting in pregnancy has also been studied. There have been 6 double-blind randomized controlled trials involving a total of 675 subjects which have been published. And ginger was statistically superior to placebo in 4 of these trials, and ginger was equivalent to pyridoxine in 2 of the trials. This has led the Cochrane reviewers to conclude that ginger may be helpful, However, there's also potentially a large placebo effect with its use. So now we get into the pharmacologic approaches to the treatment of this disorder. And anytime we talk about the utilization of drugs in pregnancy, we also have to be aware that there could be teratogenic risk. In 1979, the Food and Drug Administration came up with a classification as follows to look at or to classify a particular drug in terms of their risk. A drug would be classified as an A drug if controlled studies show no risk, a B drug if there was no evidence of risk in humans, although again controlled studies have not shown this. A type C classification basically states risk cannot be ruled out. D classification says there's positive evidence of risk, and then X classification indicates that the drug is contraindicated in pregnancy. So that drugs which are A and B clearly would be safe, C possibly, and obviously D and X you avoid. In 2015, however, this classification was removed, and the Food and Drug Administration decided to have individual descriptions of risk as opposed to use of the classification system, because it was felt that trying to put everyone into certain pigeonholes as listed would in fact, for certain indications, rule out the use of certain drugs. So this was felt to be a little more helpful to the practitioner, to be more descriptive of what's going on, and also would allow the practitioner to have a discussion about the risks and benefits with their patients in a little better fashion. So the first line treatment is the use of pyridoxine or a combination of pyridoxine and doxylamine. And this certainly has been the most widely sort of approach over the years. And as we already discussed in the first lecture, the combination of vitamin B6 and doxylamine was provided as bendectin for a number of years until 1982. But more recently, as the drug was brought back on the market, is now being provided in the United States as a drug called diclegis. From the standpoint of the evidence, it's very clear that these drugs do in fact work, as we will show you in a minute. One of the problems, though, some patients have is the expense of particularly the combination drug diclegis. And to get around this to some extent, one can prescribe the pyridoxine, but also have them use Unisom sleep tablets to provide the doxylamine for the combination. So, how well does this work? Here's data from a initial study looking at just pyridoxine. And as seen here, and this is a Cochrane review of 2010, you can see that, if any, there is only a modest benefit from the use of pyridoxine by itself. And so that the Cochrane group felt that there's limited, if any, benefit to pyridoxine by itself. However, a later review published in JAMA looked at least two studies that showed that there was benefit. In the first study by Vudavanish, there was an improvement in a so-called VAS score in the users of pyridoxine or B6 compared to placebo in terms of dealing with nausea and vomiting, or nausea rather. And also there was an improvement in the score relative to vomiting episodes. In the Weibull study, which was a smaller study of a total of 60 subjects, they utilized a pregnancy-unique quantification of emesis and nausea, and the higher score means a better benefit, and certainly the treated patients tend to have greater benefit than did the placebo patients. So this particular review felt that there was benefit to pyridoxine given by itself. As for the combination, this is data actually from the studies done with bendectin. And you can see here that you see a relative risk less than 1, meaning a reduction in the risk of nausea, vomiting, and pregnancy in these 5 studies listed here. so that there's clear evidence that the combination drug certainly is helpful for women, particularly with mild and perhaps even moderate symptoms of nausea, vomiting, and pregnancy. From the standpoint of risk of teratogenicity, which was the reason why bendectin was taken off of the market, because there was thought that maybe this caused teratogenesis, and the company had a great deal of difficulty defending all these suits. You can see that all of these studies, and I think there are 17 in number, basically do not show a consistent increase in risk. In fact, all of the studies show that the confidence intervals are bracketing 1, meaning that they are non-significant. Further, one particular areas for possible malformation were studied. You can see that when one looks at cardiac, CNS, neural tubes, and so forth, that there are no studies that clearly document any particular organ system that is affected by this combination. So from the standpoint of risk, this would be a drug, meaning that clinical studies which are randomized have in fact document no risk of teratogenicity. So if we look at our first steps in the management of patients, this is the algorithm for patients with mild to moderate nausea, vomiting, starting with the confirmation of pregnancy. We start out first with trying to, again, prevent this by, again, giving a multivitamin with folic acid, and then when symptoms occur, switching over to folic acid only. Although there are all the diet changes as shown here, you can see that they're listed as plus minus, meaning maybe they work, but it's hard to show this because there's not a lot of good data. Acupuncture certainly can be offered, but it also indicates that it may not work, yet there may be a placebo effect which benefits some women. From the standpoint of herbal supplements, clearly ginger has been shown to be beneficial, and this can certainly be utilized. And finally, when we go to the far right, looking at the pharmacological interventions for this degree of nausea, vomiting, the use of pyridoxine, but more importantly, the combination of pyridoxine with doxylamine appears to be beneficial to most women with less severe symptomatology. A key point, however, one needs to keep in mind is these patients require follow-up. So until it's clear that they have stopped the degree of vomiting and are able to keep fluids as well as potentially even food down, they should be monitored very closely to be sure that they're not slipping into significant degrees of dehydration, which would be problematic. Second-line treatment for moderate to severe cases can include intravenous fluids. There's some evidence that a combination of dextrose and saline is better than saline alone when provided to such patients. The addition of vitamin B1 or thiamine to fluids with severe cases reduces the risk of Wernicke encephalitis. The question, of course, is if you have to go to intravenous fluids, do they require hospitalization? Is outpatient or inpatient treatment better? And there are studies that indicate outpatient rehydration along with the provision of antiemetics is as effective as inpatient treatment, and that many patients can certainly be treated in this fashion. However, this requires the availability of sites where intravenous therapy can be provided, as opposed to patients presenting to the emergency room where the cost becomes something that can be prohibitive to some patients. Certainly one needs to consider hospitalization if there's vital sign changes such as persistent hypotension or tachycardia, if there's a mental status change, confusion, etc., if there's continued weight loss, particularly if it's creeping towards the 5% weight loss cutoff for hyperemesis, and obviously if the means that you've come up with for treatment as an outpatient are not working satisfactorily. If we look at the drugs that are available on this particular slide are listed antihistamines as well as 5-HT3 antagonists, ondansetron, better known as Zofran. The antihistamines are effective, as shown in recent meta-analysis. In addition, from the standpoint of side effects, one can, as shown, can have sedation, but also dry mouth, lightheadedness, and constipation are also side effects that are seen. These drugs are all categorized in the old system as B, meaning although there's not randomized clinical trials showing lack of teratogenicity, there are other studies that do, and these are safe to use in pregnancy. The use of Zofran is increasing, such that it is widely used actually in the treatment of individuals with this disorder. It certainly is effective and also is a drug that can be given orally as well as intravenously. However, one has to be a little more cautious with the intravenous dose in that it should be limited per dose to 16 milligrams or less, because by giving higher doses or higher amounts intravenously, one risks cardiac arrhythmias through an elongation of the QT interval. From the standpoint of malformations, overall there's no increased risk of malformations, though two studies do show a small increase of the risk of perhaps cardiac malformations. Certainly its use should be discussed with the patient, and certainly they should be provided with the information that overall risk of teratogenicity is not shown, but there are these two studies that perhaps modify the risk at least slightly. In addition, if we go to the next line of drugs, dopamine antagonists have often been used also in the treatment of these patients. These medications also have the advantage they can be given orally, intravenously, intramuscularly, or even per rectum. Overall, any teratogenic risk appears to be negligible, even for the composine listed above, based on several studies. However, one needs to exert care when combining these drugs. For example, Reglan, which is metoclopramide listed here, when combined with one of the phenothiazines also listed on this chart, the combination can increase the risk of extrapyramidal effects. In addition, Zofran combined with one of the phenothiazines, as we've already mentioned, can lead to an increased risk of QT interval prolongation, which also puts a patient at risk for arrhythmias. When all of these fails and you have refractory cases, the use of chlorpromazine can be considered. And again, it's the same care that we've just discussed needs to be utilized in using this in combination with other medications. In addition, the use of steroids has been utilized when all else fails. But again, this carries some additional risks. If it's used before 10 weeks, you run the risk of oral clefts. In addition, use for prolonged use may also provide effects that are not beneficial to the fetus. And of course, one has to consider how effective is the use of steroids in treatment of this disorder. And when you look at a couple of studies, and here's one of them, you can see that the rate of rehospitalization is not different when you use steroids as opposed to placebo. And in many instances, you can have persistent ketonuria as shown here, so that, again, the overall success rate with steroids is questionable. So if we look at our algorithm for moderate to severe, you can see that, again, we utilize the antihistamines or Zofran if the nausea, vomiting, and so forth is persisting and there's some evidence of dehydration. Certainly IV fluid replacement with glucose plus saline along with thiamine should be considered. And again, one can use Zofran in association with this, or other drugs such as dopamine antagonists. When all else fails, one can certainly add steroids, and hopefully one ultimately will get resolution of the symptomatology. Of course, the question then arises, what about patients who are refractory to all of these pharmacologic interventions? And these are patients, again, who continue to lose weight. Vital signs oftentimes will reveal orthostatic hypotension. And what do you do to provide nutrition until hopefully they reach well into the second trimester and the symptoms abate? The question is, should this be enteral nutrition or parenteral nutrition? All experts in the field feel that one should certainly approach this with enteral nutrition, which would include a gastric or duodenal tube, if at all possible. The risk of this particular treatment are low. The problem is that many patients will refuse the treatment, and then one is left with only total parenteral treatment. But again, this needs to be undertaken with a clear understanding that at least 50% of patients which undergo prolonged parenteral nutrition will in fact develop some complication. 25% develop line infection, which can go on to more significant sepsis. You can have superficial thrombophlebitis. Even with the use of lipid emulsions, you can also get steatohepatitis in some individuals. So again, parenteral nutrition, if used, should be used for short periods of time, and if all possible, one should use the enteral nutrition in its stead. So in summary, what we've done with these two lectures is review nausea, vomiting, and pregnancy, which includes, of course, hyperemesis. Nausea, vomiting is a common complication that interferes with normal activity and can go on to have serious consequences such as hyperemesis. Fortunately, this disorder is only seen in about 0.3 to 3% of patients. The overall etiology of this particular problem is not well understood, though the most recent focus seems to be honing in on some sort of interaction with HCG. Management is gradated and includes diet, some efforts at behavioral changes, as well as non-pharmacologic and pharmacologic measures. In general, symptoms do improve with therapy, or fortunately, the disorder runs its course over time. This concludes the two-part lecture series on nausea, vomiting, and pregnancy, which includes hyperemesis.